Hello, I'm Sarah Ray, and I'm one of the assistant professors of pharmacy practice at Concordia University, Wisconsin, and I'm excited to be working with you this semester in your pharmacotherapy course. I've been a pharmacist for almost 20 years, and a majority of my time was spent with Aurora Healthcare. I worked in community pharmacies, so I did a lot of time educating patients and talking with providers about appropriate therapy for a wide range of diseases, mostly adult patients. But then I also worked in several clinics and supervised pharmacists that were in anticoagulation clinics and our family medicine clinics. So do have a lot of experience in anticoagulation care, as well as diabetes, high blood pressure, hypertension, hyperlipidemia, and smoking cessation. In my current role at Concordia University, Wisconsin, I teach mainly in the third and fourth years of our pharmacy program, and then I also maintain a practice site at Milwaukee Health Services. It's a federally qualified health center in downtown Milwaukee, and I know that sometimes some of the Concordia master's nursing students do some of their clinical rotations there, so perhaps I shall see you there. But in my role there, I work a lot with the other providers, which includes a lot of nurse practitioners, a few physician's assistants, and some physicians. And I primarily focus on patients with diabetes at this time, but also work with patients in general on polypharmacy and needing education in regards to their diabetes, high blood pressure, hyperlipidemia, smoking cessation, asthma, COPD. So hopefully over the next 2 weeks modules, we will be able to learn a lot about the respiratory disorders and how we treat that with medications, as well as some of the endocrine disorders. So like I said, very excited to be working with you, and why don't we get started? Today we will be discussing the different classes of medicines used to treat asthma. I do have some specific objectives that are listed in Blackboard for you, but primarily we're going to be talking about the different classes of medications used and looking at how they work, how you dose it, what's some of the adverse effects to watch out for, monitoring parameters, and some other things that you should be considering when deciding what to use in your patients. The guidelines haven't changed in several years, so we're still using the 2007 National Heart, Lung, and Blood Institute, the NHLBI, Expert Panel Report 3, Guidelines for the Diagnosis and Management of Asthma. So there's a nice executive summary document that's out on the website. I have the link out there for you as well, out on Blackboard. But your text also goes through this extensively because this is the primary guideline used and it's been around for a while. I'm not sure when they're going to be doing any updates. But my assumptions in talking about the medications today is that you have reviewed the guidelines, especially the classification of asthma severity, assessing asthma control, and moving along the steps, because we'll talk about that later, but I want you to have that understanding, as well as the stepwise approach. So it's a very stepwise, start here, look at what their asthma control is, and then move on, advancing therapy as needed. So please make sure you've looked at those tables in your text, as well as the guidelines. I've also have links out in Blackboard as well to instructions on how to use a peak flow meter. That's very important. We see that a lot in our ambulatory clinic patients, children especially, but children or adults benefiting from some self-management and monitoring at home. So how to use a peak flow meter, and then the different inhalers. There's a nice website that Fairview health system up in Minneapolis is maintaining, and they have a pharmacist that has provided detailed instructions and videos on all the different inhalers that are out there. So you can just advance through those. They're alphabetically, I believe, by brand name. Not quite sure, but you can look through there. And that gives you a good feel for how the different inhalers work. That does come into play depending on the age of your patient or the dexterity level. You do need to think about using an meter dose inhaler where a patient may have trouble coordinating the breath, where then you may want to use a spacer, versus using a dry powder. Then there's no coordination needed, but you need a big breath in order to draw in the powder. So just some things to think about. Again, we really want to focus when we're working with our patients over, the continuum of care is managing their asthma. And it's really a combination of patient education, looking at controlling their environmental triggers that they may have, and then managing any other comorbidities that as I stated earlier, the classification of asthma really helps you determine where do I start with therapy. So it's very important to get a good baseline evaluation and determination of where the severity level of your patient's asthma. And then again, at various junctures, when they may have to go to the emergency department, or if they're coming in for a visit and they're using their short-acting beta agonist more often, well, then you need to assess their asthma control. Again, there's the charts that help you do that to help you determine the recommended step to take in their therapy. It might be increasing a dose. It might mean adding on therapy. So the goals of therapy, again, are to reduce impairment, reduce the risk, and use therapy that provides as much benefit as possible with as few side effects as possible. Easier at times. Again, this is a slide that just talks about, again, the impairment and the risk. The impairment are those things that, make asthma a drag for a lot of, younger patients, especially having them have a lot of breathlessness, coughing, not able to engage in their normal school activities, after school activities, sports that they may want to partake in, as well as needing their medications, needing to carry their medications with them and use them throughout the day. But we're also looking at that long-term risk. It's more than just an annoyance of waking up at night and coughing. There can be a lot of sequelae with asthma, and patients can end up in the emergency department, hospitalized for their breathing problems, and over time they can lose their lung function, lung growth in children if they're not well controlled. So we really want to reduce those risks. We're going to be talking about the bronchodilators primarily first, the beta receptor agonists, the anticholinergic medications, and I know the xanthine derivative, theophylline, falls in there as well. I included that later in the presentation just because we don't see that used very often anymore in asthma. We'll then talk about corticosteroids, which again are really the workhorse for patients with asthma. Leukotriene modifiers, some other inhaled anti-inflammatory medicines. We'll touch on omalizumab, which is an injectable medication, and then briefly just talk about oxygen. So the beta-2 receptor agonists, I think we're all very familiar with albuterol as the short-acting beta agonist. There's beta receptors in our smooth muscle of the bronchial tree, and so as we're stimulating those, then we're reversing the bronchospasm, we're relaxing the bronchial smooth muscle. There's also been some demonstration that it inhibits the release of mediators that cause a more hypersensitivity reaction, so that when you hear of patients that really have such a quick and tightening of their lungs and trouble breathing, that it can happen from those mediators. So the beta agonists work very well for patients with asthma. For most of the medications with asthma, we're talking about inhaled medications, so side effects are usually less. Warnings and precautions are usually not as prevalent. However, we do have to know that it's not just going into the lung. There's certainly some that's being swallowed, so it is getting into the systemic system, but also there are other beta receptors. So yes, the lung has the majority of it, and that's what we're targeting, especially with the inhaled medication. But there are beta receptors elsewhere in the cardiovascular system, skeletal muscles, and the CNS. So think about that when we talk about side effects. That'll help you kind of remember some of the side effects associated with beta agonists. Again, albuterol is the most common short-acting beta agonist. Levalbuterol is another one. We don't really see levalbuterol used very often just because of the cost of it, and people are just so used to albuterol. Works very quickly, lasts for roughly 4 to 6 hours. And then we have the long-acting beta agonists, salmeterol, aformoterol, formoterol, indacaterol or vilanterol. Those latter two, indacaterol and vilanterol, have a duration of 24 hours. So we actually don't see them used in asthma quite as much as in COPD. But all the other long-acting beta agonists, again, work very quickly, just like our short-acting, but they have a longer duration of about 12 hours. So for the most part, you can think of the short-acting duration of 6 hours, long-acting duration of 12 hours. Some of the adverse reactions to think about with the beta receptor agonists, again, think back to where the other beta receptors are. The majority are going to be, of the side effects are going to be from the cardiovascular system, palpitations, tachycardia. We have to be very careful in patients with cardiac arrhythmias and other heart problems. Can cause CNS excitation, tremors, that jittery feeling, headaches, insomnia. Drug interactions are pretty few just because it's an inhaled medication. There is an oral formulation, a syrup for albuterol, and there are tablets as well. In that case, you may have some problems with other cardiovascular medications because you're going to be stimulating those beta receptors in the heart with the oral medication, as well as beta blockers since they're working against that. Again, avoid use in patients with cardiac arrhythmias, and the beta agonist can cause hyperglycemia. That doesn't mean we don't use the medication in patients with diabetes. We just have to be aware of that. There is a black box warning with our long-acting beta agonists. It was reported, a while back now, late 2000s with salmeterol. That was the primary long-acting beta agonist that was in use. And it was in studies comparing salmeterol versus placebo, there was an increased risk of death, respiratory related, of course. And they also found that it may have been a higher risk in African American patients. And it wasn't clear if it was because patients were using the long-acting beta agonist as a rescue medication, which it shouldn't be used for. It's a duration of 12 hours, needs to be thought of as a controller medication, a maintenance medication. Regardless, there is the black box warning that now long-acting beta agonists should not be prescribed individually. You may just see that later on. I'll talk about it with exercise-induced asthma. But in general, long-acting beta agonists should only be used in combination with another controller medication, and usually that's going to be an inhaled corticosteroid. The FDA also recommends that you prescribe a combination product where it's one inhaler that has both the steroid and the long-acting beta agonist. That guarantees that the patient will be taking both medications. If you prescribe them individually, there's the chance that a patient may decide, oh, I can't afford the steroid, I'm just going to take the long-acting beta agonist. And again, that could be worrisome. So the dosing, I've listed there for you. Albuterol, again, the workhorse, 2 puffs every 4 to 6 hours. You're going to use it more often if someone's having an acute exacerbation, if their peak flow readings are very low in the red zone, so below 50 or 60% of their personal best. You're going to use it up to, 4 puffs potentially, but at a time, but at least 2 puffs every 20 minutes. Up to 3 times, so 6 puffs in an hour, and I've seen that go up even more than that. Again, higher risk of side effects when doing that, but if you're treating the acute exacerbation, you're not really worried about side effects quite at that point. It can be used, albuterol can be used before exercise. You give 2 puffs about 15 to 30 minutes before exercise, and it works very well. Again, the long-acting beta agonists, usually it's just 1 puff every 12 hours. Vilanterol is going to be the 1 puff a day, and Indicaterol as well. You can use the long-acting beta agonist for exercise-induced asthma. I really don't see that being used anymore because people are afraid of patients using it independently without any other controlling medication. But if so, it can be used about 30 to 60 minutes before exercise. There is a nebulized solution available. It can be used orally. Again, that's a tablet and a syrup. But really, inhalation is the best route to go. It can be utilized even in infants. There are the spacers or aero chambers available, and they come with masks of various sizes, whether it's very small for an infant, fits right over the nose and mouth, a little larger for your toddler infant, and then there's actually a larger one that you can use in an elderly patient or an adult that may not have may not be able to coordinate the breathing or is having trouble, where you can use the mask in those patients as well. Nebulizers are often thought to be better than an inhaler, especially like if somebody has severe asthma or an acute exacerbation, but that's not been proven or shown. So nebulizing the medication, it's a lot of work. There's the patient has to prep the medicine or get it in the cup. There's a lot of cleaning that needs to happen with the cup and with the tubing and replacing the tubing, and it very rarely is maintained like it should by patients. That's certainly the same thing with inhalers. We, in the pharmacy, will talk to the patient about, cleaning out that inhaler at least once a week. And we know it doesn't happen that often for a lot of patients. So we just really stress inhaler use as much as possible, and then proper use of that inhaler and cleaning. Again, adherence is really key in asthma. A lot of patients have trouble really figuring out that they need a controller medicine every day. I've worked with a lot of patients who struggle to take that controller medicine on a daily basis. They think that just taking the albuterol when they have breathing problems will fix the problem. And it does help them breathe better when they're having an exacerbation or coughing fit or trouble with the cold weather. But it's really not working long-term like an inhaled steroid is, which we'll be talking about, or even the long-acting beta agonist to really help prevent having those exacerbations in the first place. So a lot of work can still be done to help patients really recognize adherence is necessary, and then using the inhaler the proper way. So that's why I had those links to the proper administration of the different inhalers. Can be difficult for some patients. That's where the spacer can really work wonders, since they don't have to coordinate the breathing. The pharmaceutical companies are certainly working hard to create somewhat easier to use devices, and they are getting better. Again, as I mentioned earlier, the peak flow meter can really be a helpful tool for patients to start to use at home to recognize when they may start to be having breathing problems. And you can create an asthma action plan based off of that, so that when they are well controlled, they know they need their controller medicine every day. When they start to dip into that yellow zone, that's typically 60 to 80% of their personal best, that they know then, I need to increase my use of albuterol, or I need to increase my inhaled steroid dose, or I need an oral steroid, depending on your patient. And then obviously what to do in the red zone, whether that's coming to the clinic, calling the clinic, getting a prednisone prescription, using their albuterol more often. That can all be outlined in an asthma action plan. All right, so moving on, we've got the anticholinergic medications, and those work again as bronchodilators to again relax the smooth muscle in the lungs by working on the muscarinic cholinergic receptors. We typically see the anticholinergic medicines used in COPD, not asthma. When we see them used in asthma, it's typically a patient who's having an asthma exacerbation. You can use it in combination with albuterol. If somebody can't tolerate a beta agonist like albuterol because of heart problems, then you also potentially could see the anticholinergic inhaler used. And again, we don't typically see it utilized in children. If a patient has asthma and COPD, which we'll be talking about COPD in the next lecture, that's where you really see the anticholinergics. Adverse effects, think again, anticholinergic, a lot of dry mouth, hoarseness, throat irritation, some cough are really the most frequent. You do need to worry about urinary retention, narrow angle glaucoma because of the anticholinergic effects. Again, it is an inhaled medicine, so the chance of this is much lower, but just something to be cognizant of, especially in an older patient. Again, I'm only going to really go through ipratropium. There's others listed in your textbook, but we really just see ipratropium used for asthma purposes. There are many others listed that we're going to talk about in terms of COPD treatment. But ipratropium is 2 inhalations every 4 to 6 hours. It does come in combination with albuterol as a Respimat inhaler, Combivent Respimat, and that's 1 inhalation 4 times a day, so different instructions. Again, if it's used for an asthma exacerbation, and if it's going to be used then with albuterol, we commonly see it as a nebulized solution. You can get ipratropium alone as a nebulized solution, and then that's 250 micrograms 4 times a day. But it also comes, again, in combination with albuterol in a premixed solution. Same monitoring really for most of the agents applies. How to use the inhaler, the Respimat, if you've gone through that, it's quite difficult to put together. It's really easy to use once you've put it together and know that it's delivering the dose of medicine, but it's not so easy to use, to put together that first time you receive the inhaler. Next up are the corticosteroids, and again, that's really the workhorse for asthma. It reduces inflammation in the bronchial tissue, again, helps produce smooth muscle relaxation, really helps in both children and adults. There are a lot of side effects. Again, mainly we're using it inhaled, so that limits the side effects. So most of the ones I'm talking about have to do with the mouth, because if someone's not inhaling properly and getting the full dose into their lungs, they're going to get some hoarseness, tongue or mouth irritation, dry mouth. They can get oral thrush, candidiasis, so that's why we always instruct as pharmacists, and you should as well as the provider, that patients need to rinse their mouth out after using the inhaled corticosteroids. Swish and then spit out the water, and just needs to be water. That can be mouthwash if they want, but that really cuts down on the mouth irritation and oral thrush. Cataracts, obviously, just like with the oral steroids, could be an issue. There can theoretically be the hypothalamic pituitary axis suppression. Because, again, it's an inhaled steroid, but some will get systemically absorbed. But we typically don't see a problem where if somebody's been on an inhaled steroid for 10 years and then they stop, that there's not typically a problem with that. There is, again, because of systemic absorption, there is inhibited growth in children, and so you will have parents that may be alarmed or not so excited to use an inhaled steroid, but many studies have shown that in the end, children either catch up to what their height was going to be, or they're about a half, a 0.5 inch inhibition of their height. So if somebody thought they were going to be 5'9", they're not suddenly going to be 5'3" because they're on an inhaled steroid for asthma. It's just about 0.5 inch. Again, if we're giving oral corticosteroids for an asthma exacerbation, there's more side effects possible with the increased appetite, stomach irritation, jitteriness, psychosis, nightmares, that sort of thing. Very rarely do we see that with the inhaled steroids. Inhaled steroids should not be used to relieve acute bronchospasm. So again, that's what our bronchodilators are for. There aren't a lot of studies in pregnancy. It is category C. There are a few that have been utilized. Budesonide has information, and I'll be talking about pregnancy at the end as well. So usually the steroids are given once a day or twice a day. Typically it's once a day. But if it's in combination with the long-acting beta agonists, those are usually twice a day, like I said, because they're Q12 hours. So just be aware of that. You do need to have patients rinse their mouth out. Formulary concerns, or your patient is having trouble using one type of a medication inhaler, you may need to switch. There's a lot of different steroids out there. You can check the different potencies. There's a nice chart on page 927 of your booklet that does go through all the different inhaled corticosteroids and what the dosing ranges are for young children, children 5 to 11, and then kids over 12 and adults. Fluticasone is an example of a very high potency medicine, so less puffs needed. Beclomethasone is just an example of low potency, more puffs needed. That just may mean you may use beclomethasone in a younger patient that needs a lower dose and has mild persistent asthma, whereas you may think about using fluticasone because you'll need less puffs overall in a patient that has severe asthma, an adult patient with severe asthma, for instance. One thing to note on that chart on page 927, the chart is wrong. The titling up on front, if you look at the medium daily dose category, they have the child 5 to 11 and the adults flip-flopped. So do look at that and make sure that when you're thinking about doses to use in your patients, on the quiz there'll be questions, on the exam there'll be questions, that you're really looking at the right category. Adults always need higher doses than children, so in this instance. If a patient's taking both an inhaled corticosteroid and a short-acting beta agonist, which may happen where they need that short-acting beta agonist during an exacerbation, they should be using the short-acting beta agonist first, giving that one time to open up the lungs, and then after about 15 minutes or so, then use the inhaled steroid. That really helps the inhaled steroid get deeper into the lungs to really reduce inflammation, reduce remodeling of the bronchioles. Again, if we're not using oral steroids except in exacerbations, usually you see the burst treatment being used of 40 to 60 milligrams per day for 5 to 7 days perhaps. It's 1 to 2 milligrams per kilogram per day in children. It does come as a syrup in children, available for children or adults that can't swallow tablets. It doesn't taste real good because prednisone is very bitter. So they have tried to mask it. Some of the newer prednisolone solutions have a better flavor, but they're more expensive, and sometimes insurance doesn't pay for it. So sometimes you may have to mix the liquid with a little bit of chocolate or something to help with that bitter taste. Again, really the same monitoring that I talked about earlier when we were talking about the peak flow monitor and proper inhaler usage. Now we're going to move to kind of an interesting class because we're getting away from the inhaled medications for a little bit, and we're talking about an oral class of medicines. So it was very exciting when these medications first came onto the market because it was a good option perhaps for somebody that had trouble using an inhaler or didn't want to cart an inhaler around. And so these are the leukotriene modifiers, and they act as antagonists. Your textbook, again, has an error. I can't remember which chapter it's in, but they don't really say specifically that they're antagonists, so just want you to be aware of that. They're antagonists at the leukotriene receptor. That's what montelukast and zafirlukast have as their action. There is also another one called Xylutin, works a little differently and inhibits the formation of leukotrienes. And so leukotrienes, they contribute to the inflammatory process and cause smooth muscle contractions. So if you're going to antagonize that or have less of the leukotrienes, that's a good thing. So they're a controller medication because they work on the long-standing inflammatory process. So they're a very good option to inhaled steroids. Or an alternative to inhaled steroids in certain patients, perhaps. Inhaled steroids, if you look at the guidelines, are still preferred, but you may have patients, I guess where I see it is maybe in children, where if you have patients, parents that are concerned about the growth or use of steroids in kids, this could be an option, or somebody who has trouble using an inhaler. The montelukast, zafirlukast are safe in pregnancy, and montelukast can be given to kids. The side effects with the leukotriene modifiers are primarily GI upset or headaches. Patients I've seen it prescribed in really don't complain of many side effects. There are some warnings with it. It shouldn't be used in patients with severe hepatic disease. There's the neuropsychiatric events that can occur, sleep disorder, nightmares, depression, mood problems. So that is a warning. The chewable formulation can't be given to patients who have the phenylketonuria just because of the substitute that's being used to help flavor it and make it a chewable tablet. There are drug interactions, more so with zafirlukast and Xylutin. They do affect with the CYP2C9 and the CYP3A4, a lot more so than montelukast. So for many reasons, we just prefer to use montelukast. The leukotriene modifiers, again, I'm going to talk mainly about montelukast and how to dose it. Zafirlukast needs to be given twice a day and Xylutin 4 times a day, which really impacts adherence. So montelukast is primarily what we see being utilized because it is once daily. It is available in that chewable tablet for the younger children. Again, for monitoring, you need to look for adherence, that they're taking it on a daily basis. It's usually once a day in the evening. Peak flow monitoring if they have persistent asthma as well. Watching for those neuropsychiatric events as well as the hepatic function issues. The next one that we'll talk about is cromolyn. So that's just in the class of inhaled anti-inflammatory medicine. It's been around a very long time. We've seen it used a lot in children, again, as an alternative to steroids. It works in several different ways to inhibit bronchospasm and hyperreactivity of the bronchioles, and then prevents the release of the leukotrienes and mast cell degradation. So again, much more of a controller medicine, like the leukotriene modifiers. Again, safe in pregnancy, can be given to kids as young as 2, and that's where, again, you may see it being utilized. Most of the side effects, because it's an inhaled medicine, relate to that: the cough, the throat irritation, bronchospasm. Dosing, this is where, it's not as convenient as other inhalers because it's 4 times a day. So back in the old days, steroids and all the other medicines were that frequent as well. But obviously now we have the steroids that can be given once a day. So 4 times a day is not preferred. Very hard to have adherence with that. It does come as a nebulized solution as well. And it can be used to prevent exercise-induced asthma, since it has some of that bronchodilating activity. The xanthine derivatives, your book talks about it a little earlier, since it is a bronchodilator. We're talking about theophylline primarily. They work on the bronchial smooth muscles and to also help with the pulmonary vessels. They work on specific phosphodiesterases, which is important when we talk about COPD next. So just remember that in the back of your head. They have a lot of side effects, as you can imagine, since it is an oral medication. Really patients have problems with the CNS side effects. It's related to caffeine, so think about the CNS and cardiovascular side effects of caffeine, as well as diuresis. We don't see it being used in pregnancy. We do see it being given to children, and we're not going to talk about this, but obviously if you're working with a neonatal patient who is having problems with their premature birth and breathing, you'll see caffeine used. Adverse effects, like we talked about, are many, which is why we don't use it very often anymore. This insomnia, excitability, tremors, seizures could happen, the heart and cardiovascular issues. This is a medication that we monitor with blood levels, so again, not so convenient since we have to draw blood levels. The adverse effects are more likely if the blood levels are above 20, so that's reassuring, but it's still kind of a problem to monitor. We don't want to use it, again, if toxic, if patients can't remain in their therapeutic range or toxicities develop, in patients with heart problems, patients with seizure disorders, or peptic ulcer disease. There's a lot of drug interactions. It hits on the CYP3A4 enzyme, so that affects a lot of other medications, as you can see. The book lists a lot of them. I've listed some of the ones that you may see more often. And so, again, that limits the effectiveness of them. The dosing, we use weight-based dosing, up to a max of 400 milligrams when patients are first starting out. Adults, it's 6 milligrams per kilogram per day. Kids, are a little higher dosing because they work through the metabolism much faster. But again, the max is going to be 400 milligrams divided. So there are sustained release preparations available that can be given once a day, but we don't start with that. We start with TID or QID dosing, which again is hard on adherence at the beginning until you know what dose is appropriate. So you use the immediate release products initially, divided into 3 to 4 doses, and then you need to check blood levels every few days, increase the dose until you get to the therapeutic range of 10 to 20. You have to check a trough level, or a peak level, sorry. So you're looking at peak levels 1 to 2 hours after that immediate release, about somewhere 5 to 9 hours after the long-acting medication. Usually the maximum dose that patients end up taking is the 10 to 13 milligrams per kilogram per day. Children, you can see there, much of it's the same. You're starting at a higher dose. You're still checking levels. You're aiming for a lower peak of 5 to 15 instead of that 10 to 20. Same thing where you're checking the peak blood levels. Depending on the age of the child, the max dose will range from 18 to 24 mg per kg per day. This one, as I had stated earlier, omalizumab is a newer medication that is typically utilized more in moderate to severe persistent asthma, so higher up the stepwise therapy chart, especially if somebody has allergic asthma. So it's a biological medication, and it's an injectable, and it targets IgE. So it helps in the whole allergic inflammatory cascade in asthma. And we see it again in adults and kids over 12 if a patient has much more of an allergic asthma component and the inhaled steroids aren't working. Most of the side effects relate to the injection, so injection site reactions, arthralgias. It can have some severe side effects with the eosinophilia causing anaphylaxis, some reports of malignancy. You can see the others listed there. So not something that is first line by any means, but where you may see it being used, you want to typically probably an asthma specialist is prescribing that. The dosing, you have to draw IgE levels first, and then you base the dose on the IgE level and the patient's body weight, and there's charts in the package insert for the drug. It's called Xolair, omalizumab, and so that will determine what your initial dosing is, and then it's given every 2 to 4 weeks. Oxygen, again, you're not going to see that used unless somebody is having an asthma exacerbation. You're trying to treat the hypoxia, keep the oxygen saturation above 90%. Side effects, obviously, that you're going to see is if you're using a nasal cannula to deliver it, there's the dry nasal passages. You have to make sure that a patient's not getting 100% oxygen for too long of a period of time. Your book goes into this further. We'll talk about it also with COPD, where you may see it being used more chronically. The biggest warning with oxygen therapy is patients cannot smoke. And again, when you have a COPD patient who is struggling to quit smoking and using oxygen on a regular basis, that is a severe problem. I've listed the dosing there for the oxygen that you may see. Some of the counseling points that the book brings up that I want to highlight is that the controller medicines, working with your patients to make sure that those are scheduled once a day or twice a day, whatever the regimen is. Rinsing their mouth out with water after using the steroids especially. They can rinse their mouth out after using the other inhalers as well if they feel that they're getting dry mouth or coughing or what have you. You really do. Most patients have trouble coordinating the metered dose inhaler puff, so spacers or aero chambers really should be prescribed with those. What we counsel patients on and what you want to remind patients of is to not do their 2 puffs of their steroid or of their short-acting beta agonist all at once. So you'll see patients put both puffs in their mouth and be done with it. That's not going to work. It's all going to be swallowed instead of breathed into their lungs. So they need to use 1 puff, wait a couple minutes, and then do their second puff. Again, that can really impact adherence. So the more times that we can just give a once-a-day medicine or a 1 puff twice a day or 1 puff once a day is really going to be key. And again, patients should use the short-acting beta agonist first if they're also then going to use the inhaled controller steroid after that so that it can get deeper into the lungs. I briefly had talked about pregnancy earlier. Again, treatment is very similar to other adults. We don't want to stop therapy if women are concerned about the inhaled steroids. Budesonide has the most data, but you can use their other inhaled corticosteroids. Certain drugs that actually could be used during labor and delivery, you have to be careful not to use that in patients who have asthma who are getting ready to deliver, because that can worsen their asthma. Children, I think we've talked a lot about adherence and technique, using the mask, using the Montelukast tablet if needed, cromolyn if parents are concerned about the inhaled steroid use. Managing concomitant infections are really key in children. So many children get those viruses that are going around at school or daycare, a lot of infections, and that can certainly worsen their asthma. In older adults, our geriatric patients, we really just need to be aware that they could have technique issues in using the inhaler correctly, and if they have arthritis in their hands or just trouble getting a good breath, they may also be more susceptible to the side effects. So if we think about the stepwise therapy, the different classifications, so primarily for intermittent asthma, just a short-acting beta agonist when they're having symptoms. If the symptoms increase, and the charts in your book kind of talk about the guideposts there, if they then become mild, persistent, we move up to step 2. We always have the short-acting beta agonist on board as a rescue medicine. But then we usually start with the low-dose inhaled corticosteroid as our controller medicine. And then if symptoms don't improve with that, we move them up to moderate persistent. We can either increase the dose of the steroid or keep them at low-dose steroid and add on a long-acting beta agonist at that point. And then severe persistent, which would be steps 4 to 6, in the stepwise therapy. Again, our short-acting beta agonist always on board. We'd move up to high-dose steroid, or if we were on low dose with a long-acting beta agonist, we'd move up the ladder there. And then that's where you may think about adding on montelukast, or do we need the omalizumab in a patient with allergic asthma? So please look through the materials in your book for stepwise. We talked about the asthma exacerbations, short-acting beta agonists, high dose, which can create some side effects. Combine it with ipratropium, especially if you are worried about side effects, then you may need less of the albuterol component. You may need the oral steroids to help control that. Monitoring the peak flow meter, using it in collaboration with an asthma action plan, that really helps you know what what the patient's going through at home, what the patient's triggers might be, or how they perceive their disease, and helps them become educated about when they're having symptoms, what they should be doing. We look for, obviously, improved quality of life, a reduction of symptoms, not using oral steroids if at all possible, so reducing exacerbations and need for steroids of the oral nature. Really utilizing their short-acting beta agonists, their albuterol, less often. So again, patients who have long-standing asthma that's not been well controlled, they think the natural, normal thing is albuterol every day. And so again, working with the patient to say, really, we want you to use your albuterol once a month or once a week, and using your inhaled steroid every day is really the goal. Again, patients I've worked with kind of struggle with that because the albuterol is their lifeline, that's their rescue medicine, and they're just used to needing it and using it, and they don't want to give it up. So it can take a lot of education and really working with them over multiple visits to help them understand that. And again, we want to keep track of how many times a patient's hospitalized and reduce that. For patients with asthma, it's really important that we're recommending and helping to administer the annual influenza vaccine. For the most part, patients should be receiving the intramuscular inactivated vaccine. Patients with more severe asthmatic problems shouldn't be getting the live vaccine that is the inhaled, just because they can have side effects from that, and it can cause anaphylaxis or problems. And really, the young children from 2 to 4 with asthma should not be receiving that live attenuated inhaled version. Patients who have asthma should be given the pneumococcal vaccine. We're specifically talking about the PPSV, the polysaccharide 23. As you may recall, all adults over the age of 65 should be getting the PPSV 23, but if they have asthma or some other diseases, they should be getting that as an adult from age 19 to 64, 1 dose. The recommendation is to get that 1 dose and then a dose after they turn 65. For kids who have severe asthma and they're on high-dose oral steroids, then they should also get a PPSV 23. Obviously, that's not going to be the majority of your patients, but there is some instances where children should be receiving that. So that's the completion of our asthma chapter and looking at the different medications being utilized. Again, take a look at the objectives, look at the guidelines. Certainly let me know what questions you have so that we can help you do well on your upcoming quiz and exam.